Hi, I'm Steve Nichols. I'm here at the scientific sessions of the American Heart Association in Chicago, and I'm joined here today by Mark Dyer and Martin Thornhill from the United Kingdom, and they've presented really some quite provocative data on infective endocarditis in the United Kingdom. And Mark, endocarditis, we don't tend to hear a lot about that in late-breaking clinical trials these days. What can you tell us?
No, we were a bit surprised as well. In March 2008, the National Institute for Health and Care Excellence, who are a very influential body in the UK, were asked to comment on what we should do about antibiotic prophylaxis to prevent infective endocarditis. And they looked at all the data and they actually said very reasonably and very logically, there are no data to support the use of antibiotic prophylaxis. There are concerns about anaphylaxis. There are concerns about antibiotic resistance. You should stop using it. And that caused quite a reaction in the UK. So what we've been doing for a number of years now is we've been looking at how the prescriptions for antibiotic prophylaxis have fallen off. And they've really fallen off in a big way. They're down to about 10% of the level they were before the guideline change. And we've looked at the number of patients being discharged from hospital with a diagnosis of infective endocarditis. And the numbers there appear to be rising more than you would expect them to rise, such that we have probably about 25% more cases now than we would have expected to have had trends prior to the guideline continued.
And are we seeing a change in the outcomes of endocarditis in association with that?
Mortality in absolute terms has risen slightly, but not to any great extent. So we haven't seen worsening outcomes. If anything, we've seen slightly better outcomes over time.
Right, but we are seeing more hospitalisations for endocarditis. We're seeing a lot more intensive antibiotic management, and is that also translating to more surgical interventions as well? Yeah,
we've looked at the data at the people who are also having operations when they come in, and as you'd probably expect, because we've become more aggressive at operating on patients, the numbers of operations are going up.
Right. So maybe while a small hit on mortality, an enormous morbidity and kind of cost implication to kind of health systems. So Martin, you come at this from a very different perspective. From the dentistry angle. I mean, what's your take on all of this?
Well, I think there are several kind of observations. I mean, the first one is that really the response to the NICE guidelines was pretty impressive. The reduction in antibiotic prescribing, which is largely done by dentists. I mean, over 90% of all the prescriptions for antibiotic prophylaxis were given by dentists, has been very large. We've seen an exponential fall in antibiotic prophylaxis prescribing. As Mark said, we're now down to about 10% of the previous level of prescribing. So dentists seem to have followed the advice pretty closely. There is still a residual amount of antibiotic prescribing going on, and we have done surveys to see where that is being directed, and principally it is still being directed at the high-risk category of patients. So there's some evidence that some dentists, some cardiologists are kind of working with the American Heart Association or European Society of Cardiology guidelines, at least for those patients they're most concerned about.
So does this have an impact? Do we need to go back and change the guidelines?
I think it's important that the guideline committees actually have a chance to evaluate the data, and I don't think anything should be changed yet. NICE have issued a statement saying they're going to have a look at things, and they have not advised any change yet. Just because we've identified a temporal association, it doesn't mean we've identified a cause-effect relationship, and you can't do that from this sort of survey. And there may be other changes to the patterns of care, to the population, to risk factors that could equally explain this change as well. So there's more work to be done to understand why we've seen the change we have.
Right, and we do it in a world where the valve populations are changing as well, with a lot more kind of transcatheter valve procedures, and it very well may be that we have more and more individuals with prosthetic valves as well moving forward.
Well, we have looked at that to some extent, and we have put some of that data into the Lancet publication. It's actually in the appendix to the Lancet publication. And it's true, you know, more valves are being implanted, there's more percutaneous techniques being used, but so far the data doesn't suggest that the changes in that could entirely account for what we've seen. I think it's a complex issue, and most of the kind of alternative explanations we've looked at by themselves don't kind of hold up. The problem is that what we can't exclude is the possibility that a multiplicity of different causes could account for the increase in the incidence of endocarditis.
Sure, and then I guess the last thing I wanted to ask was, do we do a good enough job educating, you know, our professional colleagues? You alluded to the fact that, you know, the majority of antibiotic prescriptions, you know, occur in the dental setting. Do we need to do a better job of educating our colleagues?
I do think that there is a need for that. I mean, this really requires a close partnership between cardiologists and dentists. It's the dentist who has to operate the antibiotic prophylaxis. You know, they have to provide that cover whenever they see an at-risk patient. So there is a real need for cardiologists to kind of communicate properly with dentists so that they understand which patients, you know, should and shouldn't be receiving antibiotic prophylactic cover in whatever country, you know, according to the local kind of guidelines.
Okay, great. So Mark, take-home message.
There's been a change in the guidelines. We've seen a massive fall in the prescribing of antibiotic prophylaxis. We've seen a rise in the number of cases, but don't change anything yet. A lot more work needs to be done to understand why that rise has occurred.
Great. So this is, you know, one of those findings at one of these meetings that really has enormous implications for the way we all practice. So I wanted to congratulate the two of you on really wonderful work, and thanks for joining us today. And thanks for joining us on EHJ Today, the voice of leaders.